One of the most common spinal conditions I see in my clinical practice is spondylolisthesis. This is where one vertebra slides forward over another vertebra, causing pinched nerves in the lower back, what's commonly called spinal stenosis. This causes low back pain radiating into the buttocks, thighs, and the legs. The two most common questions patients with spondylolisthesis ask me are: 1. Do I need a surgery? And 2. If a surgery is needed, can I avoid a fusion? I'll answer both of these questions today. If a patient with spondylolisthesis has tried conservative treatment like physical therapy, medications, epidural injections, but their symptoms are still quite severe, then the standard treatment for this condition is a surgery called laminectomy and fusion. Laminectomy is where you remove this part of the bone called the lamina and you unpinch the nerves in the spine. Fusion is where you put rods and screws into the spine, into the vertebrae, to stabilize them, like this. When I discuss surgical treatment of spondylolisthesis with my patients, one of the most common questions I get asked is, can I just get a laminectomy without a fusion? The short answer is no. I'll show you today why a fusion is necessary for spondylolisthesis and why surgeons don't just do a laminectomy without a fusion for this condition. Today, you'll see two interesting cases of spondylolisthesis where the patients needed laminectomy and fusion surgery. I'm also going to show you two more cases of spondylolisthesis where I did not recommend surgery to those patients. So let's get into it. So this patient came to see me complaining of severe low back pain radiating into the buttock, thighs, and legs. Here's the MRI. If I was to slice this patient's spine straight down the middle, up and down, and look at it from the side, here's what it would look like. Here's the front of the body and here's the back of the body. These boxes are the bones, the vertebrae. You can see that these vertebrae are all lined up perfectly until we get right over here. The L4 vertebra is slipped over the L5 vertebra. This is what spondylolisthesis looks like. We're going to come back to this problem in a second. Between the vertebrae are the cushions called the discs. Behind the vertebrae and the discs is this long tunnel called the spinal canal, full of spinal fluid, which looks white on MRI. Floating within the spinal fluid are the nerves, which look like strings. Let's look at a normal level here between L3 and L4. If you were to slice the spine across in cross-section and turn it over and take a look at it, this is what it would look like. You can see that the spinal canal outlined in yellow is wide open. And here outlined in orange are the normal joints between L3 and L4 called facet joints. In contrast, if you look at the cross-section between L4 and L5, the spinal canal is very tight. This is because the facet joints outlined in orange are very arthritic and they've become huge and degenerated. Also, you can see this unusually large amount of fluid within the facet joint called synovial fluid, which is produced in unusually large quantities when the joint becomes degenerated. This abnormal amount of synovial fluid indicates that the joint is not stable. Now, the normal caliber of the spinal canal at L4-5 should be like this, outlined in yellow dots. In order to open up the caliber of the spinal canal, you have to remove this part of the bone called the lamina, which includes most of the facet joints. The surgery is called laminectomy. When you do a laminectomy, you open up the spinal canal and unpinch the spinal nerves. Now, what happens if you do the laminectomy and don't fuse the spine? Well, you have removed more than 50% of facet joints, which automatically means that the spine is now unstable. And if you don't stabilize the spine, the spondylolisthesis will gradually worsen over time, and the patient will have to undergo a second surgery, a fusion surgery, in the future. So to avoid this problem in the future, after doing the laminectomy, you stabilize the spine by placing 2 screws into the L4 vertebrae and 2 screws into the L5 vertebrae, and hook them up with a rod on each side. This stabilization is called fusion. This patient did really well after surgery and made an excellent recovery, so this was a very satisfying and successful surgery. This second patient also had a L4-5 spondylolisthesis, which I have marked right over here. The spinal canal at L4-5 is severely narrowed right over here. If you look at the cross-section at the normal L3-L4 level, the spinal canal outlined in yellow looks like this, and the facet joints outlined in orange look like this. They look great. But if you look at the abnormal L4-5 level, there's a severe problem over here. The spinal canal outlined in yellow looks very tight and narrow. The reason is that the facet joints outlined in orange, have become unusually large and arthritic, and the bone spurs are severely encroaching on the spinal canal, causing it to be almost completely pinched off. The normal dimensions of the spinal canal at L4-5 should be like this, outlined in yellow dots. So in order to open up the spinal canal, you have to do a laminectomy, which means, again, that you have to remove this part of the lamina bone, including the facet joints. Once you do this, the spinal canal has been restored to its normal size, its normal caliber, the nerves are free. The next step, again, is to stabilize the vertebrae by doing a fusion using rods and screws like this. This patient also made an excellent recovery, did very well, very successful and satisfying surgery. Now, as a comparison, I'm going to show you two cases of spondylolisthesis where I did not recommend surgery. This is pretty interesting. This patient has a spondylolisthesis at L4-5 like this. What's interesting about this patient is that he did not have any radiating pain into the buttock, thigh, or leg. His only complaint was localized lower back pain. The MRI shows that the spinal canal at L4-5 is not narrowed. When you compare the cross-section at L3-4 with the cross-section at L4-5, the spinal canal outlined in yellow is not significantly narrowed. Also, the facet joints outlined in orange at the L4-5 level are not overgrown and arthritic. Since this patient did not have neurological problems, I did not recommend surgery. Instead, I suggested a combination of physical therapy, anti-inflammatory medications, and pain management procedures, and the patient did very well with these treatments and did not need surgery. This next patient also had spondylolisthesis at L4-5, best seen on the X-ray right over here. The patient complained of only back pain and, very importantly, did not have any neurological complaints radiating into the buttocks, thighs, or legs. Looking at the side view of the spine, the MRI shows that the spinal canal is wide open, and you can see it on the cross-section at L3-4 and also L4-5, outlined in yellow. The facet joints at both levels, outlined in orange, are also about the same size. I also recommended non-surgical treatment to this patient consisting of physical therapy, anti-inflammatory medications, and pain management procedures. The patient did very well, did not need surgery. So the take-home points from this video are: spondylolisthesis with stenosis and neurological problems requires laminectomy with fusion. Spondylolisthesis without stenosis, without neurological problems, can sometimes be managed successfully with non-surgical treatment. Thank you for watching. See you next time.